As we are slowly gathering to get started again, just for your planning, I think we're going to go ahead with a couple of public comments that relate, one to PCV13, the other to meningococcal disease. Then we're going to break and ask Dr. Santoli to come up and present, because I'm told you have a relatively short presentation. And that way you don't have to stick around. And then we'll move into the meningococcal section. And then I think we're going to have one final public comment following, but we'll try and get everybody out the door as advertised by 1:30 or so. So thank you very much for your patience. That being said, if we could have Rich Greenaway and Tama Lee come up to the microphone. And I think Rich is going to be making a comment on PCV13. Again, we ask to limit comments to about 3 minutes. State your affiliation and any conflict of interest. Thank you.
I'm Rich Greenaway. I'm representing the Immunization Coalition of Washington, D.C., and I have no conflict of interest. I'm just really impressed with the presentation that we got this morning about PCV13, and I think that it is really important that the ACIP consider this for movement and encourage the ACIP to, in light of this new data and in context of the disease burden, to take the additional steps necessary and meet in August and do something so that we can help to prevent disease in the fall, which, we can't just shelf the fact that we've got a vaccine. I mean, we can't forget about the fact that we have a vaccine just because it's inconvenient for us to follow through and get all the players to work on it and basically, pay for the vaccine. I like the idea of putting the 50-year-old recommendation in play, because then we don't have to worry about people that are on public health plans. Their personal health plans will pick it up. So I just encourage the ACIP to look at this and consider it in August.
Thank you very much. And is this Tama Lee?
Yes.
Do I pronounce that correctly?
Tama Lee.
Tama, okay.
With the National Meningitis Association, no conflicts. First of all, I'd like to congratulate the CDC for working so quickly to address the outbreaks at Princeton and UCSB and providing meningococcal B vaccinations and symptoms education for the students and faculty at those campuses. As most of you know, NMA was founded by parents like me who have been devastated by the loss of a child due to meningococcal disease. I lost my son, Casey, in 2000, and I've worked with NMA since it was founded in 2002. Since then, immunization community has made great strides in meningococcal disease prevention. Teen vaccination rates are up at a high, all-time high, and disease incidence is at a historic low. But we can't stop now. This disease is devastating, and it still affects families all across America. Soon we'll have the ability to provide routine protection against serogroup B disease in adolescents. Just within this past year at NMA, we've heard from and met many families whose lives have been changed forever because of serogroup B disease. I'm here today on their behalf. We have all worked together over the years, advocates, policymakers, public health experts, healthcare professionals, and vaccine manufacturers. We cannot now pass up opportunities to provide better protection for our children. I hope this committee considers this as discussions surrounding meningococcal B vaccines continue. Thank you.
Thank you very much for your comments. I'm going to just mention again for everyone, the registration will open June 27th for the October 29-30 meeting, as shown above, easily found on the ACIP website. As Larry said, register early and register often, just early. And if we can ask Dr. Santoli to come up with an update on vaccine supply.
Hello there. I was going to cover two different topics in today's updates: pertussis-containing vaccines, influenza vaccines, and then, of course, as always, to remind you about the vaccine supply page. In terms of pertussis-containing vaccines, the update is that the supplies of Pentacell and Daptocell and Atacell vaccines have steadily increased during 2014, and actually during the second quarter, the availability of additional supplies of these vaccines has allowed both the VFC and private providers to be able to order the products without restrictions. GSK continues to have sufficient supply of Pedierix, Boostrix, Infinrix, and Kinrix to cover the anticipated demand as the Pentacell, Daptocell, Atacell products continue to increase, but the presentation preference may be impacted on occasion. And by presentation preference, I'm referring to vials versus syringes, an equivalent product, but a different way of being delivered. In terms of influenza vaccine supply for the upcoming season, I think many of you know that each year at the National Influenza Vaccine Summit, U.S. licensed flu vaccine manufacturers provide projections of flu vaccine production for the U.S. market for the upcoming season. And CDC reaches out for periodic follow-ups as we get closer to the season to confirm and adjust manufacturer projections. In May of 2014, manufacturers projected an aggregate total of approximately 157 million doses of vaccine for the upcoming season. As you know, the projections always come with the important and appropriate caveats of that there needs to be sufficient lot release, that the yield must be what it is, what's necessary to support that projection, and also that demand from customers who are pre-booking still in the May timeframe supports that level of projection. A follow-up in June of 2014 resulted in a revised projection of a range that's between 153 and 158 million doses of vaccine. And the changes in these two projections are due to a couple of factors. First, there were adjustments made by some manufacturers based on the demand for vaccines during the pre-book process that was not yet completed when the information was shared in May. And then second, GSK has recently updated their projections from 35 million doses to a range of 28 to 33 million doses. And this was following a warning letter from the FDA that related to an inspection of the Flu-Laval influenza vaccine manufacturing facility in Canada. GSK also produces Fluarix. It's manufactured at a different facility, and it is not impacted by the warning letter. And then lastly, just a reminder that we update this website regularly so that there's information between these meetings about what we know about vaccine supply for the routinely recommended vaccines. And I will stop there.
And any questions or comments for Dr. Santoli?
Okay.
Thank you very much.
Thank you.
And Dr. Laurie Rubin will go ahead and introduce the meningococcal vaccine section.
Well, good afternoon. Yes, I'd like to acknowledge on this slide the work group members, including Jessica McNeil, the CDC federal officer. The session today will deal mostly with outbreaks of meningococcal disease and the potential use of serogroup B vaccines. At present, a meninge B vaccine has not been licensed in the United States, but there are two investigational vaccines under development. Both vaccines have received a breakthrough therapy designation from FDA. Pfizer Vaccines has submitted a complete biologic license application to FDA, and Novartis Vaccine has submitted a rolling BLA to FDA. This Novartis vaccine is licensed in Europe, Australia, and Canada. In 2013, two universities experienced outbreaks of serogroup B meningococcal disease with a combined 13 cases and 1 death reported. And meninge B vaccination campaigns were conducted at both universities in response to these outbreaks using an investigational meninge B, the one from Novartis vaccines, which was obtained through an expanded access investigational new drug, or IND, application sponsored by CDC. With this development, an ad hoc committee was developed, the Meningococcal Outbreak Work Group. This ad hoc work group consisted of ACIP meningococcal work group members, ACIP members, state public and health officials, college health professionals, and CDC. And this work group convened, the first meeting was January 30th of this year with bi-weekly meetings. There are 3 objectives of this work group. The first 2 you'll hear about today. The first is to review available data on the recent epidemiology of meningococcal disease and outbreaks, to develop guidance for the use of meningococcal B vaccines under a CDC-sponsored IND in an outbreak setting, and then ultimately to update the current meningococcal outbreak guidelines once meninge B vaccines are licensed in the United States. So today's session will cover the epidemiology of meningococcal disease outbreaks in the United States. That'll be presented by Sarah Meyer. And we'll suggest interim guidance for the use of a serogroup B meningococcal vaccine under a CDC-sponsored expanded access IND, presented by Jessica McNeil. No votes will be taken at today's session. And just to talk about other meningococcal workgroup activities. Just last week, the policy note on the use of Memvio in infants at increased risk for meningococcal disease was published in MMWR. This publication summarizes the use of 3 meningococcal conjugate vaccines in children 2 through 23 months of age at increased risk. And then the workgroup is also discussing the approach to recommendations for the use of serogroup B vaccines once they are licensed. Thank you.
Good afternoon. In this presentation, I will review the epidemiology of meningococcal disease in the U.S., outbreaks of meningococcal disease, and results of the recent evaluation of clusters and outbreaks in organizational settings. Since the early 2000s, rates of meningococcal disease due to all serogroups, including serogroup B, have declined to historic lows in the United States. In addition, vaccination coverage of the adolescent MenACWY vaccine has increased in recent years since introduction in 2005. With this high vaccination coverage, serogroup B is now the predominant cause of meningococcal disease in the adolescent age group, as opposed to prior to vaccine introduction when serogroup C and Y were the most commonly reported. Despite the higher rates of serogroup B disease in adolescents, it is important to note that the overall burden of disease is very low, with an average of 29 cases reported annually from 2010 to 2012 in 11 to 24-year-olds. Outbreaks of meningococcal disease are rare in the United States, historically causing only 2 to 3% of U.S. cases. Reports of school and organization-based clusters or outbreaks are uncommon in the published peer-review literature. From 1989 to 2004, during the pre-MenACWY vaccine era, 22 school-based outbreaks were reported in the U.S., 7 serogroup B and 14 serogroup C outbreaks. The majority of these outbreaks consisted of 2 or 3 cases. Little difference was seen between serogroup B and C outbreaks in terms of duration of the outbreak and interval between reported cases, with a median of 3 days between cases for serogroup B and 2 days for serogroup C. Since 2009, 5 universities have reported serogroup B clusters or outbreaks, with 2 to 13 cases reported in each. With these most recent university outbreaks factored in, as well as a serogroup C outbreak in an elementary school in 2010, the size of outbreaks appear larger, with more outbreaks reporting greater numbers of cases. In addition, the median interval between cases is increased, creating a more indolent pattern for serogroup B outbreaks. However, it is unclear if these differences are real or if the differences are related to increased recognition of cluster-associated cases in the setting of historically low disease rates. In summary, serogroup C meningococcal outbreaks are less frequently reported since high coverage with the adolescent men ACWY vaccine has been achieved in the U.S. The three most recent university-based serogroup B outbreaks appear atypical compared to previous outbreaks with greater number of cases reported and longer interval between cases. In light of these recent serogroup B outbreaks, an evaluation was conducted to understand the current epidemiology of meningococcal clusters and outbreaks in the United States. Prior to revising guidance for use of meningococcal vaccines in outbreak settings, including use of an unlicensed serogroup B vaccine under a CDC-sponsored IND, it is important to understand the full breadth of epidemiologic features of meningococcal clusters. This includes identifying previously unreported clusters and understanding whether the recent serogroup B university outbreaks are representative of the current epidemiology of meningococcal disease outbreaks. Although information on outbreak-associated cases is collected through NNDSS, reporting is likely incomplete. Complete and systematically collected data on clusters and outbreaks of meningococcal disease occurring in the U.S. is important when evaluating outbreak guidelines. Thus, a retrospective review of meningococcal cases reported since January 1st, 2009, was conducted by state health departments and CDC to identify clusters of meningococcal disease. An EpiX announcement with a call for cases and clusters was published on January 24, 2014, followed by a standard questionnaire administered to each state. For the purposes of this evaluation, a meningococcal cluster is defined as 2 or more cases of the same serogroup in an organization in less than or equal to 3 months, or an increase in disease rates of the same serogroup in a community or specific population in a community at rate 2 times the rate during the same period in prior years. A meningococcal outbreak is defined as 3 or more primary cases of the same serogroup in less than or equal to 3 months, and clusters and outbreaks are classified as either organization or community-based. From January 1st, 2009 to December 31st, 2013, 3,745 cases of meningococcal disease were reported in the U.S. through NNDSS. 18 states reported 71 clusters or outbreaks through the EpiX announcement. 52 clusters met the cluster definition, with 207 cases comprising 5.5% of all U.S. cases. Among these, 22 clusters also met the outbreak definition for 146 cases, or 3.9% of all U.S. cases. All subsequent analyses represent primary cases from clusters meeting the cluster definition. This figure demonstrates the number of cases reported by month for cluster-associated cases and sporadic cases. Cluster-associated cases occurred throughout the year and in each years of the evaluation. This figure depicts the geographic distribution of cluster-associated cases and sporadic meningococcal cases in the U.S. As seen here, the distribution of clusters is widespread. The number of clusters per year has ranged from 6 to 17. The majority of clusters in the United States are community-based clusters, shown in blue, with 37 reported from 2009 to 2013. 14 organization-based clusters and 1 unknown cluster were also reported. Given the need to develop interim guidance for the use of unlicensed serogroup B vaccines under a CDC-sponsored IND in organizational settings, I will focus the rest of the presentation on results from organization-based clusters. In terms of serogroup distribution, approximately 60% of organization-based clusters are due to serogroup B, compared to approximately 35% of sporadic cases. This table shows the characteristics of organization-based clusters. The median population size of the cluster is over 14,000 persons. The median number of cases per cluster is 3. The median duration of the cluster is 48.5 days. And the median age of cases in organization-based clusters is 19 years, compared to 35 years among sporadic cases reported in NNDSS. The case fatality ratio in organization-based clusters is 17%. Among the 14 organization-based clusters reported, 7 occurred in universities. 1 cluster in each of the following were also reported. A fraternity party associated with university's Parents' Weekend in which parents of the student became ill, a long-term care facility, correctional facility, meditation center, a homeless shelter, an elementary school, and a hockey league affiliated with the university. Among the 7 university-based clusters, 2 were due to serogroup B. The number of cases per cluster ranged from 2 to 8, and the duration of the cluster from 2 to 245 days. The next slide examines university-based clusters in more detail. Among the 7 university-based clusters, 5 were due to serogroup B. The number of cases per cluster ranged from 2 to 10. The median number of days between cases ranged from 3 to 75 days, for a total duration of the cluster of 25 to 616 days. The overall case fatality ratio in organization-based clusters is 17%, but differed by serogroup. Serogroup B clusters had a case fatality ratio of 6.1%. In serogroup C clusters, the case fatality ratio was 42.9%. In the setting of historically low cases of meningococcal disease, meningococcal clusters account for a greater proportion of cases than in years past and are likely recognized and reported more readily. A substantial proportion of organization-based clusters are associated with universities and are due to serogroup B. The 3 recent serogroup B university-based clusters have appeared atypical compared to clusters in years past in terms of number of cases and duration. However, the course of a cluster is unpredictable, and it is difficult to determine if and when additional cases will occur. The comparison of current meningococcal cluster or outbreak epidemiology to historical data has limitations. Over time, there have been changes in the definitions, recognition, and reporting of meningococcal clusters. In addition, advances in molecular genotyping may alter the interpretation of which cases are associated with a particular cluster. Regardless, meningococcal disease clusters and outbreaks cause substantial concern, necessitating a public health response. In conclusion, serogroup B organization-based clusters are rare and heterogeneous, limiting the ability to make definitive interim vaccination recommendations based on data alone. Interim guidelines for use of serogroup B vaccines under a CDC-sponsored IND should provide concrete guidance, yet allow for the flexibility to evaluate each outbreak on a situational basis. I'd like to acknowledge the state and local health departments who assisted with this evaluation, as well as the meningococcal outbreak work group. Thank you.
Thank you. Are there any questions or comments regarding the session with Dr. Meyer? Then I think let's go ahead and move along with Ms. McNeil.
Good afternoon. In this presentation, I will be reviewing the interim guidance that has been developed for the use of a serogroup B meningococcal vaccine under a CDC-sponsored Expanded Access Investigational New Drug Application, or IND. There is currently no vaccine for serogroup B meningococcal disease, or MEN-B, licensed in the United States. Recent outbreaks on college campuses highlight the difficulty and challenges of controlling serogroup B meningococcal disease. Vaccination campaigns were conducted at 2 universities experiencing serogroup B outbreaks in 2013 using an investigational MEN-B vaccine developed by Novartis Vaccines under an expanded access IND sponsored by CDC. FDA's current regulations allow for the use of a drug or vaccine that is not approved in the United States to treat serious or immediately life-threatening diseases or conditions when there are not comparable or satisfactory alternative treatment options. The mechanism allowing such use is known as an expanded access IND. In January of this year, an ad hoc meningococcal work group was convened to evaluate available data on the recent epidemiology of meningococcal disease and outbreaks, and to develop guidance for use of meningococcal vaccines in an outbreak setting. I want to acknowledge the work group for rapidly coming together to create the guidelines that I'm presenting today. The working group's terms of reference included 3 main objectives: reviewing available data on the recent epidemiology of meningococcal disease and outbreaks, developing guidance for use of MEN-B vaccines under a CDC-sponsored IND in an outbreak setting, and considering options for updating the current meningococcal disease outbreak guidelines once a MenB vaccine is licensed in the United States. The first two of these objectives have been completed, and their outcomes are being presented in today's session. Once a MenB vaccine is licensed in the United States, the working group will complete the final objective. During the development of the interim guidance, several key issues and challenges were discussed based on our experience with providing MenB vaccine under an IND mechanism at the two universities experiencing outbreaks in 2013. When providing a vaccine under an IND, there are additional steps to getting a vaccination campaign in place. Therefore, there's a need to consider options early in an outbreak. In addition, there was a need to reduce confusion about how to define populations within organizations and a recognition that waiting for additional cases to occur before acting is difficult for organizations, and there needed to be clear steps for each case outlined in the document. Finally, there is no evidence that MenB vaccines eliminate carriage, so providing primary protection to individual vaccinees must be the goal of the vaccination in this setting. The current comprehensive meningococcal disease outbreak guidelines are included as an appendix in the 2013 Prevention and Control of Meningococcal Disease MMWR. In these guidelines, vaccination of a population at risk should be considered when 2 to 3 cases of the same serogroup occur during a 3-month period with an attack rate of 10 per 100,000 in the affected community. This threshold was based on data from outbreaks of serogroup C prior to routine adolescent meningococcal vaccination. However, defining the denominator for calculating an attack rate in the affected community is often challenging for health departments and organizations. The population at risk can be either defined as organizational-based when cases have a common affiliation but no close contact, or community-based when cases occur in the same geographic area but no close contact or affiliation is identified. The purpose of the interim guidance document that I'm presenting today is to identify outbreaks, serogroup B outbreaks early, so that there is time to vaccinate in response to the outbreak if it is determined to be necessary. The current document provides guidance for use of MenB vaccine using an expanded access IND sponsored by CDC, but it does not provide definitive guidelines or recommendations. In this document, we have tried to simplify the criteria for when vaccinations should be considered, and importantly, this guidance applies only to serogroup B outbreaks in organizational settings and does not apply to community outbreaks or outbreaks caused by other serogroups. This guidance is only intended to be in place until a licensed vaccine is available in the United States, which may be as short as a year. Before I summarize the language that's included in the guidance document, I wanted to highlight 3 key differences between the interim guidance document that I'm presenting today and the comprehensive outbreak guidelines that were published previously. In the interim guidance, recommendations for organizations are divided into 2 groups based on organizational size, versus requiring calculation of an attack rate. The interim guidance also increases the time frame during which cases may occur from 3 months to 6 months. And finally, the language around mass chemoprophylaxis has been revised to allow for some instances where it may be considered for use in conjunction with a vaccination campaign for outbreak response. The objectives of the interim guidance document are to assist decision makers with determining the need for vaccination with MenB vaccines, to clarify the process of obtaining a vaccine, and to improve the timeliness of implementation of vaccination campaigns. Clear definitions are provided in the guidance document for cases that should be included in an outbreak case count, what represents an organizational-based outbreak, and how to determine population size in the vaccination group. Serogrouping of clinical specimens should be initiated within 24 hours of identification of Neisseria meningitidis from a normally sterile body site whenever possible. Laboratories that cannot initiate serogrouping within 72 hours should transfer the isolate or specimen to a laboratory that can perform this testing or to CDC within 24 hours. Genotyping data may also provide supportive evidence of an outbreak of meningococcal disease among cases, and the data from isolates should be interpreted in the context of the epidemiology of the cases. Decisions to vaccinate should be evaluated on a situational basis in consultation with the local and state health department and CDC, taking into account all of the circumstances specific to the organization and the epidemiology of the outbreak. Factors that should be taken into consideration include the number of cases, population size of the organization, time interval between cases, If the strain causing the cases is identical, the feasibility and cost of the vaccination campaign, vaccine availability, if the outbreak strain is likely to be covered by a MenB vaccine, and public concern. The working group has divided its guidance by organizational size, beginning with organizations with less than 5,000 persons. When one case of meningococcal disease occurs, routine public health practices should be followed, including serogrouping of the isolate, conducting a case investigation, and providing prophylaxis to close contacts. The situation should be monitored closely, and the isolate should be saved for future molecular genotyping. In organizations of this size, the trigger point is reached when 2 or more cases occur within 6 months. The recommendation is to complete all of the same public health response activities as following a single case, and in addition, all isolates should be sent to CDC for molecular genotyping and additional testing. If all isolates are identified as serogroup B and likely covered by a MenB vaccine, then a MenB vaccination campaign may be considered. In organizations with more than 5,000 persons, the recommendations are similar after a single case. When 2 cases occur in 6 months and both are identified as serogroup B, then the state health department should contact CDC to discuss the cases and continue to monitor the situation closely. In organizations of this size, the trigger point is reached when 3 or more cases occur in 6 months. Isolates should be sent to CDC for molecular genotyping and additional testing, and if all isolates are identified as serogroup B and likely covered by a MenB vaccine, then a vaccination campaign may be considered at that point. CDC will work with state and local health departments and organizations, as just described, to determine the need for a MenB vaccine on a situational basis. Organizations that provide MenB vaccines via the FDA's Expanded Access IND, sponsored by CDC, are required to identify a local co-investigator on the IND and are required to participate in safety follow-up activities as required under the IND. To date, universities implementing a MenB vaccination campaign have been responsible for funding both the cost of the vaccine and its administration, and vaccination under CDC's IND has been limited to persons affiliated with the 2 universities where outbreaks have occurred. In developing the interim guidance, the working group also felt it was important to better understand the current recommendations and available data on the use of mass chemoprophylaxis for outbreak control. A review of the literature from 1971 to present was completed, and 18 instances where mass chemoprophylaxis was used as part of outbreak response was included. The working group's conclusions from this review were that there is limited data available on the use of ciprofloxacin for mass chemoprophylaxis during outbreaks, but that overall decreases in carriage were seen soon after chemoprophylaxis was administered. Carriage was not eliminated and generally returned over time, and there was an unclear impact of mass chemoprophylaxis on prevention of additional cases. The purpose of chemoprophylaxis is to eradicate nasopharyngeal carriage of Neisseria meningitidis and thus prevent disease in close contacts of a patient with invasive meningococcal disease. Antimicrobial chemoprophylaxis of close contacts is important to prevent secondary cases. The guidance emphasizes that mass chemoprophylaxis is not recommended as a standalone measure to control outbreaks of meningococcal disease and should only be considered as an interim measure to reduce carriage and transmission in the period before potential protection from vaccination can be achieved. Situations where mass chemoprophylaxis is most likely to be successful include smaller closed populations, where high antibiotic coverage can be rapidly achieved, and there is limited mixing with outside populations. There are several challenges to successfully implementing a mass vaccination or mass chemoprophylaxis, including identifying a smaller logical at-risk population, ensuring all persons in the target group receive treatment within a short time frame, the potential for multiple sources of transmission within a population, the prolonged risk for exposure in an outbreak setting, the cost of the drug and its administration, drug side effects and idiosyncratic reactions, interactions with frequently used medications, such as antidepressants, and the emergence of drug-resistant organisms. If mass chemoprophylaxis is undertaken, it should be administered to all persons in the targeted population at the same time, and ideally in less than 24 hours. In many outbreak settings, particularly when a small, closed, at-risk population cannot be defined, the disadvantages of providing mass chemoprophylaxis outweigh the possible benefits to prevent future cases. If the decision to implement mass chemoprophylaxis prior to implementation of a vaccination campaign is made, communicating the need for vaccination for potential protection for the duration of the outbreak is critical. Additionally, use of mass chemoprophylaxis should not delay implementation of the vaccination campaign. Other control measures, such as restricting travel to an area with an outbreak, closing schools or universities, or canceling sporting or social events or meetings, is generally not recommended as part of outbreak control because these interventions are unlikely to alter the course of an outbreak. However, educating communities, physicians, and other healthcare personnel about meningococcal disease to promote early case recognition and early care-seeking behaviors is an important part of managing suspected meningococcal disease outbreaks. These education efforts should be initiated as soon as an outbreak is suspected. We plan to publish the interim guidance document on the CDC website shortly after this meeting so that it will be available to interested health departments and organizations before the next school year. As mentioned previously, updates to the CDC's comprehensive meningococcal disease outbreak guidelines will be developed and shared with the ACIP once serogroup B meningococcal vaccines are licensed in the United States. CDC will also work to identify opportunities to evaluate the impact of using MenB vaccines as part of outbreak response. In summary, meningococcal disease is a rare but serious infection. Fortunately, outbreaks are rare, but they do occur, and the timing of additional cases in an outbreak is not easy to predict. We know that we will continue to see serogroup B cases occurring, especially in the adolescent age group, which means that it is difficult to differentiate between sporadic cases versus catching an outbreak in its early stages. Vaccination is now possible to control serogroup B outbreaks, but implementing a vaccination campaign under an IND is a complex process. Licensure of serogroup B vaccines in the U.S. will be an important step to protect individuals during serogroup B meningococcal disease outbreaks. Thank you.
Thank you very much for the presentation. I'm wondering if Dr. Sun might be able to provide us with any information on current status of licensure for vaccines in the United States.
Since a lot of this information is now in the public domain, yes, right now we have both the two manufacturers, Novartis and Pfizer, who have submitted licensing applications to the FDA, and they're under current review. And because they are, both these products were given the breakthrough therapy status, that review process is more abbreviated. And so, but still, it's a process in which we have to review all the data, and so ideally we would it would be and this is a pending review, of course. If all goes well, I think the timing for the regulatory decision will be at the end of the year or early part of next year.
Thank you, Dr. Dushan.
Thank you for this presentation. So I have two questions. One is, you mentioned that you're in the process of revising the meningococcal outbreak guidelines in general. Is it okay to assume that you're going to move the current, ACY recommendations more in line with what you've done here for meningococcal type B disease? So in case we have those outbreaks, we can sort of look to this as more of a accurate guide as to what we should be doing. And the second question is, what do we know about the impact of the vaccine on carriage rates in the outbreak settings?
So the main focus of the working group so far has been on developing these interim guidance. So we haven't really started working on the full revisions, but I think the idea is to move more toward this model versus the calculation of an attack rate. But we'll have to wait and see what happens after the MenB vaccine is licensed. In terms of carriage from these vaccines, there's really not a lot of evidence to support that these vaccines will eliminate carriage once you have it or potentially prevent you from acquiring carriage. So maybe someone from Novartis could address that as well, or Amanda.
Dr. Warshawski.
Brenna Warshawski from the National Advisory Committee on Immunization. Thanks for the presentation. I just had a question about the number of cases, the cutoff. So you said 2 cases in a smaller group, less than 5,000, and 3 in a larger group. And then you mentioned doing genotyping. Is that to tell whether it matches with the meningococcal strains in the covered by the vaccine, or is it to tell also if they match each other? Because if you had two different strains circulating, would you still, that cutoff still apply?
So the molecular genotyping would be to see if the strains match each other and that you're dealing with the same strain. There's additional testing that's done to determine if a vaccine would be covering that strain. And I think we've tried to make the guidance relatively flexible so that we could look at each situation independently. Sometimes there's changes in the genotype during an outbreak, so they may not exactly match, and we don't want to set up a situation where we can't do something because of our guidelines. So we're trying to be flexible and leaving the situation open. But yes, you would generally just vaccinate at 2 cases in less than 5,000 people or 3 cases in more than 5,000 persons.
Even if they didn't match, or only if they match?
What, Amanda?
So I think if you look at the genotyping data from almost every outbreak we've had in the last several years, they always match, or they're very close, and over the course there's a small change. I think to answer the question specifically about whether or not, if there is a small change, if one's covered by the vaccine and another's not, our expectation is that most strains will be covered by these vaccines. But I think that issue would have to be addressed if that occurred. But I think people felt like in the college community especially, even if you had 3 or 4 cases that didn't match genotypically, it would still be causing the same amount of concern in the community, and the drive towards vaccination would still be there.
Dr. Schaffner.
Yes, thanks, John. From the National Foundation for Infectious Diseases, we'd like you to become aware of a new report from the NFID entitled Addressing the Challenges of Serogroup B Meningococcal Disease Outbreaks on Campuses. The report was based on a roundtable that NFID held in April this year with CDC colleagues, external public health experts, as well as some college health officials. Some of the experts are familiar to you all: Paul Offit, Carol Baker, and Jim Turner. Let me just share briefly a few key points from the panel's conclusions, and they complement in a lovely way the very nice presentation by Dr. McNeil. First, despite its rarity, the severe nature of meningococcal disease makes advanced planning, particularly in the college setting, very advantageous, if not imperative. The second is that increased efforts are needed to educate healthcare professionals and raise awareness about the early signs and symptoms of meningococcal disease so that cases can be identified promptly. Third, educational resources need to be readily available for the public when outbreaks do occur. And lastly, obviously, as we've been discussing, licensure of meningococcal serogroup B vaccines will have the single greatest impact on improving the timeliness of responses to these outbreaks. Copies of the report are available on the table outside and also at the NFID website. Thanks.
Thanks, Bill. I have Dr. Zahn and then gentleman at the microphone.
Thank you. It's a great presentation. A couple of questions. One is, does the IND have an expiration date? In other words, now that you can do it, I know there was a campaign, for example, in Santa Barbara in the springtime, and my understanding is there haven't been more cases, but there is another case. Is there a period of time which they're kind of given license, they can use this vaccine again? And I guess I'm thinking about the freshman population that's going to be coming in. And do you vaccinate them or not? Do you do wait for more cases? And is that all included under the IND, just in terms of logistics, out of curiosity?
So there isn't currently an expiration date on the IND. Each university had a separate amendment done for the IND, so each university is considered as a separate group, and any future outbreaks would have to be considered separately as well.
Comment.
Rino Roppoli from Novartis. I'm trying to answer to the question about whether meningococcus B will prevent carriage. And as you know, it's very difficult in a clinical trial before licensure and the implementation of vaccination to determine whether a vaccine is going to prevent carriage. Nevertheless, we did a study in United Kingdom that is hopefully it will be published soon. The study shows that there is an impact on Neisseria meningitis carriage. Is Obviously, the numbers are low, so when you go down, you break down in serogroups and B specifically. I mean, the things become less statistically significant, but the impact on the overall meningococcal carriage is there. There is also a published paper from auto-membrane vesicle vaccine, which has been used in Normandy, where basically that prevented carriage by 60%. That's what they report. So data are preliminary, hopefully will be published soon before you have to make the decisions. And there is evidence that at least auto-membrane vesicle vaccines containing auto-membrane vesicle containing vaccines do prevent part of carriage of Neisseria meningitidis.
Thank you for that information. Other questions? Okay, thank you very much. And at this point, I think we move along. Have Dr. Reingold go ahead and introduce the update on the hepatitis work group.
Vaccine be used simply in outbreak control, not a universal.
Okay. Okay, thank you. This is going to be a relatively brief report. I think the ACIP has indicated they would like a heads up to know in advance what working groups are doing, and so this will be by nature of one of those reports. Certainly there's no expectation of a vote, and this is really primarily just for informational purposes. If I can remember. Yes. In years past, ACIP did have a working group on hepatitis vaccines, but that has not been active in recent years, and a decision was made earlier this year to reactivate or redevelop a working group on the hepatitis A and hepatitis B vaccines, two of our important early vaccines in our armamentarium. And so here you can see the members of the working group. Kathy Harriman, the other ACIP member, a number of individuals with expertise from a variety of settings. The CDC lead is Noel Nelson, and Trudy Murphy from the hepatitis division has also been instrumental in helping us get ourselves organized. This is simply to remind you that we do have existing ACIP recommendations, both for the use of hepatitis A vaccine and for the use of hepatitis B vaccine. You will notice that the hepatitis A recommendations date to 2006, the hepatitis B to 2005 and 2006. And so the primary purpose of reconstituting a working group is to oversee the revision of these two sets of recommendations to bring them to the ACIP for consideration and presumably for approval. That's not to say that there haven't been updates made around the use of both vaccines in the interim. So there are a series of documents that update recommendations, in this case for hepatitis A, and the primary role of the working group with regard to hepatitis A will be to bring all of these various documents together into a single up-to-date set of recommendations around the use of hepatitis A vaccine. To remind you that after a number of years of interesting challenges trying to deal with hepatitis A outbreaks and hyperendemic areas and interesting innovative ways of trying to use the vaccine, a decision was finally made in 2006 to recommend hepatitis A vaccine as a routine immunization for all children ages 12 to 23 months of age. So that was in 2006, about 8 years ago. This is to show you that in terms of, based on NIST data, for children in the 19 to 35 month age group, while the target in the 2020, for 2020 is in the range of 85% with 2 doses, we're currently at about 53%. So certainly there is room to improve coverage with hepatitis A vaccine. At the time the recommendation was made, there were no recommendations for catch-up in older children or in older individuals. At the moment, looking at older adolescents 13 to 17 years of age, we currently have coverage of around 48% with 2 or more doses of hepatitis A vaccine. I think it should be obvious to everyone that in about another few years, this age group will begin to see the effects of the vaccination of children 12 to 23 months of age. That'll begin to appear in 2018 when these cohorts of children born coming of age after the recommendation will begin to reach adolescence. So over the next several decades, of course, we will have a more fully vaccinated population. But at the moment, large numbers of adolescents are unvaccinated. Large numbers of adults are unvaccinated. And so this is also another area of interest, is basically the working group is going to consider a couple of different issues at the moment in the area of post-exposure prophylaxis. The recommendation for people under the age of 40 is to receive hepatitis A vaccine, but for people over the age of 40, the emphasis is put on use of immunoglobulin. And so in large part because of a dearth of data about the vaccine and its effects in people over the age of 40 in terms of immunogenicity and other aspects of the response. So the working group will be looking at the question of whether or not anything should be done to change the recommendation around post-exposure prophylaxis in older individuals. At the same time, we expect to discuss issues about whether any other high-risk groups might benefit from immunization. Suffice it to say that we know that there are foodborne outbreaks in which food handlers with hepatitis A are involved, and they are very expensive outbreaks for local and state health officials to deal with. On the other hand, anyone who works in restaurants, my son is a busser of dishes in 2 restaurants, can tell you that the turnover in people working in restaurants as food handlers is extraordinarily high. In California, many of them are quote, undocumented and don't necessarily have regular access to health care. So I think the question of vaccination of food handlers will raise a number of challenging issues for health departments. Nevertheless, the working group will be discussing the question of whether any other high-risk groups might benefit from hepatitis A, and we expect sometime in the future to bring to the ACIP any of these issues that might require further discussion and a fully integrated, up-to-date statement around the uses of hepatitis A vaccine. Similarly, as I've already indicated for hepatitis B, the last full set of recommendations are now a number of years old. There have been a number of updates published, and with regard to the hepatitis B vaccine, the working group's mandate, again, is to take all of these documents and create a fully integrated, up-to-date document describing the uses of hepatitis B vaccine. So I can't give you a more specific time frame in terms of when we will be bringing these to the committee for discussion, but that's the work that the working group is engaged in, and I'd be happy to take any questions.
Thank you very much. Any questions for Dr. Rengold? Just make an observation of, I think the fact that 50% of American adults have worked in a restaurant at one time in their life. So there is actually a fairly high level. We do have one public comment from Kara Peters, if she is here and can come up to the microphone. And this is on hepatitis A, and please state your affiliation and any conflicts of interest. Thank you.
Hello, I'm Cora Peters, and I'm here today representing the adult industry. I'm here today to tell you, as you know, that adult performers are at high risk for STDs. I want to specifically talk about hepatitis A. MSM are considered a high-risk group for hepatitis A, presumably because of sexual behaviors that put them at risk of infection. But female and male adult performers who are not MSM regularly engage in the same high-risk behaviors as MSM. And because of this, I believe ACIP should consider recommending that all adult performers be given occupational high-risk status. Adult performers are not getting hepatitis A vaccinations, and I believe if it were made a specific CDC recommendation, that they would be more likely to protect themselves and each other by getting vaccinated. We don't know how common hepatitis A infection is among performers because the industry does not currently test for it. Although they did add hepatitis B to the panel in August of last year. I know ACIP requires evidence before making any new recommendations. So what I'd like to request is that the new hepatitis A work group take up this issue, and if studies suggest that all adult performers are at increased risk for hepatitis A, which I believe they are, then they should consider recommending the vaccination for them. I think that that would make what is a risky lifestyle choice a little safer. Thank you for your time.
Thank you very much for the comment. Do we have any other comment? Any further discussion? Seeing none out there, again, I want to thank all of our liaisons, all the people in the audience for your participation, our ACIP members for your attention over the last day and a half, and to our departing members, who, two of which have already departed, but Dr. Quinn Beasley and Dr. Jenkins, and then Dr. Dushin for your 4 years of incredible service. We thank you greatly. Travel well.